Hello everyone and welcome to our module on intravenous anesthetics. Intravenous anesthetics are drugs that are used as part of anesthesia and are administered intravenously as opposed to the inhaled anesthetics that I talk about in another video. And you can break the intravenous anesthetics into two groups, the induction agents and adjuvant agents. Induction agents are used to induce anesthesia. They can be administered rapidly through the intravenous route to quickly put a patient to sleep. There are three intravenous drugs used as induction agents. Those are propofol, etomidate, and ketamine, and we'll talk about all three of these in this video. Adjuvant agents are intravenous drugs that are given to supplement the effects of the induction agents. By using these drugs together with induction agents, you can often use a lower dosage of the induction agent and therefore expose the patient to less risk of adverse effects. Drugs in this group include opioids, benzodiazepines, and lidocaine. We'll talk about all of these in this video. These drugs are not given alone for anesthesia, but they can be given together with induction agents. We'll start by talking about propofol, which is one of the most commonly used drugs for anesthesia. Propofol is used to induce anesthesia in stable patients, and the word stable is very important. As we will see shortly, this drug can cause hypotension, so you don't want to use it in an unstable patient. But when patients present for elective surgical procedures as outpatients and are in generally good health and stable, this is the drug of choice to induce anesthesia. Propofol modulates GABA receptors in the brain, and by doing so, it causes sedation and amnesia. Importantly, it's not an analgesic, so it can't be used to treat pain. It's a white liquid. It looks like what's shown on the screen. Some people call it mother's milk, and it has a very rapid onset and offset in minutes, so it can quickly put a patient to sleep, but once you stop administering the drug, the patient will quickly wake up. The reason propofol is so popular for inducing anesthesia is because in addition to causing sedation and amnesia, it has many other beneficial effects. It's an antiemetic, so patients don't wake from surgery feeling nauseous and having vomiting. It's an anticonvulsant. It also stops itching as an antipyretic. It's also a bronchodilator. And then in addition to all these beneficial effects, it can be safely used in liver or renal impairment. The main adverse effect is what I mentioned before, hypotension. Propofol causes both vasodilation and slightly decreased contractility, and this can lead to a fall in blood pressure. So you have to avoid this in hypotensive patients, and that's why propofol is usually not used in unstable patients. It's used in stable outpatients who need to be put to sleep for surgery and other reasons. Usually drugs that cause hypotension will cause a reflex increase in the heart rate, but there's actually only a minimal change in heart rate with propofol, and that's because the drug slightly blunts the baroreceptor reflex. Propofol also causes dose-dependent respiratory depression, so many times when patients are induced for anesthesia with this drug, they have to be intubated. If you're not going to intubate the patient, you have to use a lower dose of propofol and carefully monitor the patient's breathing status. And then lastly, propofol is famous for causing pain on injection. It irritates the veins when it goes into the body. If you co-administer lidocaine or opioids, which we'll talk about later, this can reduce the amount of pain at the injection site. There's also less pain at the injection site if you infuse through a central vein, but if you're using a peripheral vein, that's when this venous irritation often occurs. Okay, moving on, let's talk about etomidate. Just like propofol, etomidate is used to induce anesthesia, but etomidate is the drug of choice in unstable patients, and that's because it does not cause hypotension. Similar to propofol, it modulates GABA receptors, causing sedation and amnesia. Also similar to propofol, it's not an analgesic and does not treat pain. The major advantage of this drug over propofol is that it's relatively hemodynamically neutral. It has very little effect on heart rate and blood pressure, and therefore it's good to use in hypotensive patients. Just like propofol, it has a rapid onset and offset, so it can quickly put a patient to sleep and they will quickly wake up once you stop administering the drug. Also, just like propofol, it's an anticonvulsant, and for this reason it can be useful in stroke patients who are prone to seizures. In contrast to propofol, which has antiemetic effects, etomidate often causes nausea and vomiting. This happens in up to 30% of patients, and that's why propofol is the drug of choice in stable patients who can tolerate the blood pressure changes with the drug. You can get pain at the injection site with etomidate just like you can with propofol. This occurs by the same mechanism of venous irritation. Just like with propofol, you can minimize the pain at the injection site if you co-administer lidocaine or opioids, or if you use a central vein for infusion. Etomidate can cause some patients to have muscle jerks. These are called myoclonic movements. This is because the drug has some effects in the subcortex where it leads to disinhibition of subcortical structures, and that's what leads to the muscle jerks. If you co-administer opioids or benzodiazepines with etomidate, this will limit the amount of myoclonus. And then lastly, etomidate causes a transient and mild acute adrenal insufficiency. It has some inhibitory effects on cortisol synthesis. For patients without adrenal disease, this usually isn't a major issue, but you have to be careful if there's a reason that the patient might have adrenal insufficiency, or if the patient is on chronic steroids, where their adrenal glands are chronically suppressed and underactive. The last induction agent is ketamine. This is the least popular of the three induction agents. It's usually only used as a backup if the other options aren't available. Ketamine is a derivative of PCP, which is an illicit street drug. It antagonizes the NMDA receptor, which is the receptor that glutamate binds to in the brain. By doing this, it can induce anesthesia, but one of the effects of blocking NMDA receptors is that you get a significant increase in sympathetic nervous system activity. So when you administer ketamine, patients will have their heart rate, their blood pressure, and their cardiac output rise. They also will experience bronchodilation. You can also see constriction of pulmonary vascular structures that raises the pulmonary arterial pressure. And so these effects are what make this the least popular of the induction agents. As we'll talk about in a minute, there are many patients who need induction of anesthesia but can't tolerate the rise in blood pressure. Just like propofol, it has a rapid onset and offset, and unlike propofol and etomidate, ketamine does have analgesic properties and can block pain. So the sympathetic nervous system activation is the main problem with ketamine. This is dangerous in certain patient populations. For example, patients with ischemic heart disease or systemic hypertension can't tolerate the rise in blood pressure. Patients who have pulmonary arterial hypertension can't tolerate the increase in pulmonary artery pressures. The same is true for patients with right heart failure. They can't tolerate the rise in pulmonary artery pressures. Another adverse effect of ketamine is what's known as emergent reactions. These are symptoms patients experience when they're emerging from anesthesia. When patients come out of anesthesia that was induced by ketamine, they can be very disoriented. They can also report experiencing vivid dreams or nightmares or sometimes hallucinations that can be very frightening. You can reduce these effects by co-administering a benzodiazepine with the etomidate, but once again, because of the emergent reactions plus the sympathetic nervous system effects, these things together make ketamine the least popular of the induction agents. In the hospital, when patients abruptly develop respiratory failure, they often need to be intubated very quickly, and the way this is done is through a procedure called rapid sequence intubation. This is the standard practice for emergent intubation of a patient with respiratory failure. The idea is to administer drugs that render the patient sedated and flaccid very quickly so that you can then manipulate the jaw and insert the breathing tube like what's shown in this picture here. The drug of choice for inducing anesthesia in this setting is etomidate, and this should make sense to you after what we've just been talking about. The lack of hemodynamic effects of etomidate make it very useful. This drug will not drop the blood pressure. It also won't raise the blood pressure if the patient has comorbidities that make high blood pressure intolerable. If you don't have etomidate available, you can use alternative agents, but you have to keep in mind the side effects we talked about previously. So you can use ketamine, but remember that will raise the blood pressure. You can use propofol, but that will lower the blood pressure. And then sometimes benzodiazepines or opioids are administered in addition to one of the induction agents. For paralysis, the drug given with etomidate is succinylcholine, which I talk about in another video. Succinylcholine is the only depolarizing neuromuscular blocker, and it will paralyze the patient. As an alternative, you can use some of the other paralytic agents like rocuronium or vecuronium. So back to this slide, we've now talked about all the induction agents. Remember that propofol lowers the blood pressure and therefore it's used in stable patients. Etomidate is hemodynamically neutral, so that's a drug of choice in unstable patients. And then ketamine raises the blood pressure, and therefore you can't give it to patients who aren't able to tolerate a higher systemic blood pressure or higher pulmonary artery pressure. Now we're going to move on and talk about the adjuvant agents. Let's start by talking about opioids. Opioids act on opioid receptors, which you can find in the brain, in the spinal cord, and in nerves. And opioids have sedative and analgesic effects. They're sedatives in that they make patients sleepy, and they're analgesics in that they are powerful drugs to block pain. And remember that we talked earlier about how some of the drugs used in anesthesia like propofol have no analgesic effects, so those drugs are often given together with an opioid so that the opioid can provide analgesia. Opioids do not have any amnesia effects, so they can't be used alone for anesthesia. You have to use them with another drug like propofol. And the opioid that's commonly used as part of anesthesia is intravenous fentanyl. Some of the advantageous effects of opioids are listed on this slide. One of the major ones is that opioids suppress airway reflexes, and this is very helpful when patients are intubated. Having a tube in the throat is very irritating, and it can cause a stress response in the patient where the patient develops tachycardia and hypertension. You can avoid some of that response if you administer opioids along with other anesthesia drugs. As we talked about earlier, opioids can reduce the pain from the intravenous injection of propofol or etomidate into peripheral veins. And in addition, opioids have sedative effects which help to reduce the dose requirement of other drugs. Some of the downside of opioids is that these drugs can cause hypotension as well as respiratory depression. And then when you administer opioids during a surgical case with anesthesia, after the case the patient often has postoperative opioid adverse effects. These are things like nausea and vomiting and constipation from the decrease in GI motility that goes along with opioids. Opioids also make it difficult to urinate, so patients can have urinary retention. And then some patients, especially elderly patients, can develop delirium from opioids. Let's talk about benzodiazepines. These drugs bind to GABA receptors, leading to an increase in GABA activity in the brain. At low dosages, benzodiazepines have anti-anxiety effects. They are anxiolytics, and they're often used in the outpatient setting for this purpose as oral drugs. At higher doses, like are used in anesthesia, benzodiazepines cause sedation and amnesia. They are also anticonvulsants at higher dosages. The benzodiazepine that's usually used as part of anesthesia is intravenous midazolam, which is also called Versed. This is a short-acting benzodiazepine, so it's very useful for brief procedures like endoscopy. Midazolam can also be given as a continuous infusion as an adjunct to anesthesia for longer surgical procedures. Some of the beneficial effects of benzodiazepines are, first of all, they are anxiolytic prior to procedure. These drugs are very helpful when patients are anxious before surgery in the pre-op area. They can be given a low dose of a benzodiazepine, and this will help to relax them before surgery. They're also useful because they cause amnesia, and if any element of a surgery could lead to a seizure, these drugs are anticonvulsives. And then lastly, the sedative effects are helpful because they reduce the required dose of other anesthetic drugs. There really aren't many adverse effects of benzodiazepines. These are generally very safe drugs that it is hard to overdose on. They can cause a mild fall in blood pressure, and there is some dose-dependent respiratory depression with benzodiazepines. The last drug we'll talk about is lidocaine, which is a local anesthetic, and it is sometimes administered intravenously as an anesthesia adjunct. It blocks sodium channels in nerves, and this can be helpful in anesthesia for a couple of reasons. First of all, you can block some of the activity of sympathetic nerves, and this will limit the sympathetic response during surgery so that patients don't develop tachycardia or hypertension. Lidocaine also can suppress the cough reflex, which is very helpful when patients are intubated. This prevents them from coughing and having a choking sensation when the tube is in their throat. And then lastly, just like other adjuvant drugs, lidocaine can reduce the pain at IV injection sites of propofol or etomidate. When given at the appropriate doses, lidocaine really only has a couple of adverse effects you need to worry about. It can increase the hypotensive effects of other anesthetics like propofol, so you have to watch the blood pressure when you give lidocaine. Also, lidocaine is an antiarrhythmic drug. It's an example of a class 1 antiarrhythmic drug, and all the drugs in this class have a slight blocking effect on the parasympathetic nervous system, and by doing that they speed conduction through the AV node. So in patients who are in atrial fibrillation, when you give lidocaine systemically, you can see a rise in the ventricular rate. So you have to watch the heart rate in patients who are in AFib who are being given lidocaine as part of anesthesia. I'll finish this video by briefly discussing the stages of anesthesia as they relate to intravenous anesthetic drugs. In the video on general anesthesia, I talk about how you can break down anesthesia into 3 stages: induction, maintenance, and emergence. In the induction stage, we use drugs to put the patient to sleep, and this is when an intravenous induction agent is often used. For example, IV propofol together with an opioid like fentanyl is often used. Remember that propofol doesn't have any analgesic effects, so it's usually given together with an opioid to deliver the analgesic effects to the patients. During the maintenance phase, drugs are administered to keep the patient asleep. This is when inhaled anesthetics are sometimes used, but also intravenous anesthetics can be used, or sometimes even a combination of inhaled and intravenous drugs. So although we talked about propofol as an induction agent in this video, you should be aware that it's also often used for maintenance. It's a very popular drug for maintenance. The patient can be given a continuous infusion of propofol plus fentanyl for pain control, and this can be used to maintain anesthesia during long operations. And that concludes our module on intravenous anesthetics.